here in Salt Lake City, and a pleasure to be here as part of Synergy 2010. I'd like to take this opportunity, first of all, to thank Dan Higginson, Dan Norman, Mark Rosales, because without the symbiotic relationship we have with Synergy, the study would not have been possible. And I'd like to thank the leaders of Synergy for supporting us in conducting this research, which I think is extremely useful, not only for everyone, especially for our patients. Thank you very much. What I'm here today is not to talk about a product per se. I'm going to talk about the science of the product. I've been using L-arginine since 1998, when it became available to us in a non-commercial form, and we've been using that in our patients, but until proarginine came along, we did not push that product all that much. So what is L-arginine? L-arginine or proarginine? The main ingredient is a component where it converts into nitric oxide. Nitric oxide is ubiquitous in our body. That is, every cell, every tissue has nitric oxide and has the ability to synthesize nitric oxide. It is extremely important for hemostasis. That is, how our blood vessels function, how our cells function. It is extremely important in cardiology, especially. This is what, if this patient shows up, the patient is dead. And what we do as cardiologists is to prevent this from happening. What we are trying to attain is prevent an acute MI from taking place. An acute MI is when a cholesterol plaque that is built up in the coronary anatomy ruptures, occluding the artery, causing a heart attack. We want to prevent that from happening. And whatever it takes, in terms of aspirin therapy, in terms of Plavix, in terms of beta blockers, in terms of cholesterol lowering, this is what we have done. We do that to prevent this from happening. Acute MI occurs when a plaque in the artery grows as time goes on. It may take anywhere from 10 years to 50 years for the plaque to grow. And the plaque growth is secondary to multiple factors in terms of your diet, in terms of your genetics. It is important in terms of the physiology of the artery itself, why certain people are more prone to having myocardial infarction, having coronary artery disease, why they have strokes, peripheral vascular disease, but they have inability to walk because of occlusion of those arteries. Anywhere blood flows, those arteries can occlude, and they cause specific symptoms. May it be chest pain with angina, maybe claudication when you walk because of blockages to the leg, or stroke, or TIA, transient ischemic attack, because of lack of circulation to the brain. So as cardiologists, as physicians, we want to prevent this from happening. What can we do to help? We always institute standard therapy. Standard therapy includes aspirin because it affects the platelets that causes thrombus to form. We want to start patients on cholesterol medication because by reducing cholesterol, less cholesterol builds up in the arterial wall and therefore less chance of it blocking. Despite all these attempts, disease still progresses. And we are always looking for new ways to modulate, to kind of attenuate the progression of disease. All of us die. All of us will die. It is the quality in which we live is what we are trying to attain. And proarginine and L-arginine and nitric oxide helps us in fighting that process that is ongoing in every one of us. I'm just going to skip over this slide because this is a cartoon that is not going to work because we are in MAC. Nitric oxide, as I said, is ubiquitous. That means every cell has it. It is a direct vasodilation. Vasodilator means it enlarges your arteries. So if you have a 3 millimeter artery, if you were to give nitric oxide infusion into the artery, you can make it into a 4 millimeter artery. Therefore, it makes more blood flow into the tissue that the artery is supplying. It is also antithrombotic, which means if you have a tendency to form clot, by taking L-arginine or proarginine, you can convert it into nitric oxide And nitric oxide prevents platelets from aggregating, prevents clots from forming. It is also anti-inflammatory. When I started off in medical school and we talked about the inflammation of arteries, people used to laugh at us. Because what are you guys talking about? Inflammation? Come on. That's nothing to do with coronary artery disease. Now all research is based on and the anti-inflammatory effect of medication, how we can prevent inflammation. Because that is the injury that occurs when you have too much cholesterol, too much smoking, diabetes, obesity. All that increases the inflammatory potential of our body. That means if you were to measure the inflammatory markers, they will be elevated in a person who smokes, the person who has got diabetes, and therefore our therapy is directed towards decreasing inflammation in our body. If you take a look at a person who's 100 years old, you'll notice that their inflammatory markers are extremely down. So that tells you longevity is directly related to the amount of inflammation you have in your body. Nitric oxide is also anti-proliferative. Part of the injury that occurs in the artery, the result of injury to the arterial wall caused by hypertension, smoking, diabetes, results in proliferation, growth, division of cells called smooth muscles within the arterial wall. That proliferation, that division, that growth contributes to atherosclerosis. Nitric oxide directly prevents the proliferative effect is caused by cholesterol, hypertension, or smoking. So therefore, all these benefits are derived from nitric oxide. So, nitric oxide reverses vasoconstriction. It decreases blood pressure because when you vasoconstrict, when your arteries shrink, blood pressure goes up. So when your arteries dilate, blood pressure goes down. And therefore, nitric oxide, proarginine, has got anti-hypertensive effect. It prevents clots from forming, therefore decreases the incidence of strokes and heart attacks. It has got anti-inflammatory process, decreases inflammation, and decreases proliferative process, therefore smooth muscles do not proliferate, therefore reduces the chances of restriction or constriction. What are the causes of low nitric oxide? These are the causes. These are not all the causes, these are just the major causes. There are over 300 different conditions that reduce nitric oxide, and that list is only growing. That includes hypertension, obesity, hypercholesterolemia, diabetes, heart failure, atherosclerosis, aging, smoking. All this causes the nitric oxide in our body to decrease. It is not that the body is not making enough nitric oxide, but these things consume nitric oxide. Therefore, they're utilizing nitric oxide, and the body is not able to keep up the pace of trying to fight these disease process. So we need to take, just like we take vitamins, we need to take something extra to support our system in terms of a nitric oxide. When you have these conditions, hypertension, obesity, hypercholesterolemia, heart failure, so you want to add more, just like you want to take more vitamin C. You want to fight infection, because these conditions lower the nitric oxide. There are certain genetic conditions that actually decreases the amount of nitric oxide an individual makes. Those people, those patients are more prone to having these conditions too. As I said, every cell in the body makes nitric oxide. So it is only fair that nitric oxide plays a role pretty much in every tissue, every organ system. So nitric oxide is important not only in the circulatory system, it is also important in the nervous system, it is important in the muscular system, it is important in the immune system, and it's also important in the digestive system. You name a system, nitric oxide has got some role in it. In the nervous system, it is very important how nerves talk to one another. This communication between one nerve to another is how memories develop. If you are able to deliver more blood supply and more nutrients to the nervous system, then your nervous system develops adequately. If you are not able to deliver more nutrition, more oxygen to the nervous system, then the appropriate circuits that need to develop do not develop. People have difficulty with memory if you do not have adequate blood supply, adequate oxygen, adequate nutrition, adequate glucose delivered to the system. Nitric oxide is not a direct neurotransmitter, but it aids in this circuit formation. It's extremely important in the development of proper circuitry in the nervous system. Nitric oxide, as I said, is a vasodilator. It delivers more blood to a tissue. When more blood is delivered to a tissue, more oxygen, more byproducts, bad byproducts are also eliminated adequately, so that the toxic effect of breakdown products do not build up in the tissues that can cause you to have detrimental effect. It is a so-called free radical scavenger. Free radicals are oxidative chemicals that are generated by every tissue in our body that actually damages our tissue. Nitric oxide is like a scavenger. It is a sponge that just absorbs these bad radicals that are circulating around before they cause damage and eliminate them. It is important in muscle physiology. I want to talk to you about muscle physiology a little later, but it's very important in muscle physiology, how muscles develop, how we put on muscles in terms of how our exercise capacity is. It is extremely important in the development of exercise physiology. It is obviously important in the immune system because it scavenges free radicals, the bad elements that destroy normal tissue. By scavenging the free radicals, we also help the immune system from being damaged by the free radicals. That it helps in the fight against infection. May it be virus, may it be bacteria. So it is extremely important in the normal functioning of the immune system. It is important in the digestive system as well. Similarly, bringing nutrients into the stomach, into the intestine, how our food is processed, how blood supply is delivered to our stomach, decreases spasms, decreases symptoms of abdominal constriction, abdominal spasms. Therefore, it's extremely important in irritable bowel syndrome. Patients who have got irritable bowel, early data now suggests they have decreasing amounts of nitric oxide. Well, all this research, initial understanding of nitric oxide, came about by these three gentlemen. They won the Nobel Prize in 1998 for the discovery of nitric oxide. It's a very landmark discovery. Only now, think about it, their discovery was in the 1990s, 1980s. It took us 30 years to truly understand how nitric oxide is impacting us today. We did a study, and I think Dan Austin just briefly mentioned the study. The study was, we have a philosophy in our institute in the sense that we will try something when we have already exhausted everything that we can do in medicine. There's no harm in trying something novel. If we don't, then medicine dies. If I cannot try something new, then I might as well give up practicing medicine. Medicine is progressive, and we need to be. And so Dan Austin brought me this compound called pro-arginine, and I said, can we use it? And I said, let me look at the ingredients. As true to myself, I looked at it, and I knew what the active ingredient was, which was L-arginine. And I said, you know what, there is no data that suggests it's not going to work. I've been using L-arginine since 1998. I think, why don't we? In fact, why don't we start a trial? And with the support of Synergy, he just did just that. We looked at multiple parameters. Our study was simply to have objective data point. I did not want to have somebody coming and telling me after taking something, say, oh, I feel great. That means nothing to us in medicine. You have to have something great that you feel with something objective that I can measure. Because if I don't, if I were to go to my colleagues and say, my 10 patients felt great, they say, good luck. Because I can give you a glass of vodka and make you feel good as well. So I need to have tangible evidence that we are doing something good for our patient. So we measured multiple data points. And these are the data points that were important to us. Bad cholesterol, we did not find any significant decrease in bad cholesterol with supplement of proarginine. Remember, all these patients were maximally medically managed. That means they were already on cholesterol medication, they were already on blood pressure medication, they were taking aspirin and Plavix, whatever they needed to have to keep their heart and circulatory system going. So, but HDL cholesterol, high density lipoprotein, is the good cholesterol. That good cholesterol reverses coronary artery disease, decreases the higher the level, decreases stroke, peripheral vascular disease. It is an antioxidant. It's like a free radical scavenger. It transports cholesterol out of your arteries into the liver, it's metabolized, and therefore it gets rid of bad cholesterol. That level went up by 18%. Triglyceride, it's a bad cholesterol. It's a form of cholesterol. It's fat. Also decreased by 40% by taking proarginine. These were other parameters we looked at. A lot of our patients are diabetic. Glucose went down by 8%. C-reactive protein is a measure of inflammation. It's a measure of how much inflammation you have in your system. It went down by 25%. Creatinine is a measure of kidney function. The higher the creatinine, the worse your kidney function is. And therefore, in patients with diabetes, hypertension, who already have some stigma of renal insufficiency, it went down by 11%. Magnesium is extremely important in cardiovascular function. It is very important for neuronal function. Its levels went up by 35%, but that should go up because it is part of the supplements of proarginine. The platelet function went down. We could not measure it. We will measure it in our next study. Our albumin, amount of albumin or protein that is spilled in the urine is indirectly proportional to renal function. The higher the albumin that your urine is secreting, the worse off you are in terms of kidney function. So all our therapies directed towards reducing protein in the urine, that went down by 70%. Vitamin D level went up 183%. It has to. If it doesn't do it, if it doesn't go up when the ingredient that they're giving has vitamin D, that means that the stuff doesn't work. So it tells you that proarginine's vitamin D composition is being absorbed by the body and is available for our tissue. Our systolic blood pressure, that is the first number in your blood pressure, went down by 13%. The bottom number in the blood pressure, which is the diastolic blood pressure, went up by 17%. We looked at ankle brachial index, ABI, that is, there should be no difference in the blood pressure between the leg and the arm. But in patients with peripheral vascular disease, patients who have got atherosclerosis in the leg, that ABI index is low. And thus, index went up in patients with diabetes, patients who have got peripheral vascular disease, because it increases blood flow into the circulation. We also were able to measure the central aortic systolic pressure by a B-Pro machine that was given to us on a loaner courtesy of Universal Health. Central pressure went down, which is incredible because central pressure is directly related to strokes, to the formation of abdominal aortic aneurysm, thoracic aneurysm. So lowering the central pressure was extremely important for us. We also wanted to see all these numbers are great, but how does it affect the patients themselves? Are they able to do more? We wanted to have an objective method of looking at, seeing, all right, we've lowered the blood pressure, we have lowered the C-reactive protein, we've increased the HDL, we have vasodilated this, we have done that. Great. But does it translate into some means of increasing physical activity? And that's exactly what 6-minute walk test is. A standardized test that to see how fast and how far a patient can walk within 6 minutes. So if they're able to do more within 6 minutes, the better they are off. And that number went up. So let me give you a couple of case presentations, because these are very drastic. You know, you cannot see the same drastic improvement in everybody. But these were the patients that improved so dramatically that caught our eyes, and we said, you know what, we should push on forward. This is Angelo Sissi. Anybody who's known, this is Angelo. And he came in with severe shortness of breath. And when we measured, he had pulmonary hypertension. Just like systemic hypertension, that is having blood pressure problem, you can have isolated pulmonary hypertension, that is pressures within the lungs are very high. The lung pressure usually is 30 millimeters of mercury. Peripheral blood pressure obviously is around 110 to 120, but pulmonary blood pressure is actually really low. It is only 30 millimeters of mercury. In Angelo, it was 96 millimeters of mercury. That is almost systemic. When that happens, the right side of the heart fails. You get your legs swell up, your liver gets congested, your intestines do not work, because just like your legs swelling up, the intestines also swell up. So he was in dire straits. We were running out of options. We were about to start him on so-called pulmonary hypertensive medications like Triclear. The cost of Triclear, a month's worth of Triclear, is $6,000. A month's worth of Remodulin is around $6,000. And some of these patients are on 3 pulmonary hypertensive medications. Some of them have to be infused intravenously, continuously. So they have infusion pumps. But before we went to that, we said, why don't we try allogeneic? Can't hurt. And well, to our surprise, here he is today, not being admitted to the hospital since he started on. His pulmonary pressure has dropped to 96 millimeters of mercury, 76 millimeters of mercury. Even though it is still not normal, it is significant for a patient with end-stage pulmonary hypertension. Okay. That 30 to 40% decrease in pulmonary pressure is the difference between him being bedridden in a hospital and being attending here and eating high salt content diet. The second patient is a patient I think Dan Austin alluded to. Is a patient with severe angina. He already had bypass surgery, he had angioplasty, we have put him on maximum medication, yet he was continuing to have symptoms. And in that patient, by putting patient on allogeneic, we were able to improve microvascular flow. That is coronary flow reserve. It's a fancy word, meaning the small vessels. We were able to increase the flow, and that patient now is essentially angina-free. Okay. This is a patient with diabetes with severe ulceration of the extremities, and again improving microvascular flow. We were able to improve healing. Now this patient probably would have healed by themselves, but it would have taken 6 months longer. So by increasing microvascular flow, we are able to shorten the healing period that is required to heal the wound to about 6 weeks. Okay. So what's next? Where do we go from here? We should not be sitting on our laurels and say, well, that's great. I think proarginine offers a tremendous opportunity for us in medicine, for me, in my patient population. Where do we go? One dose doesn't fit all. That is what we are learning today. You will have patients who are taking arginine, and then they'll say, you know what, I feel great. Another 5 will come back and say, I don't feel any difference. Why is that? You go to a doctor, you have blood pressure medication that is given to you, and they put you on blood pressure medication. Next day you go in, your blood pressure is perfect on that medication. The second patient doesn't work. You have to titrate up on the medication, you need to add a second drug, because one dose doesn't fit all. And that is what we are finding out even with proarginine. One dose doesn't fit all. We need to be able to measure each individual's requirement for nitric oxide. because each individual is going to have different nitric oxide requirement. And we think we should measure it. If there's a direct way of measuring, so much the better. Indirect way of measuring, so much the better. Whatever we can, if we can measure a form of nitric oxide byproduct, then we can tailor the patient for the right dose of nitric oxide in terms of proarginine. Then I think we'll have greater benefit. So we're going to start a research on that aspect, seeing whether different dosing regimen would be helpful for different patients. And so we are looking into that. We also need to look at there's a whole science of exercise physiology. In the 1960s, when Gatorade came about, Gatorade was glucose with some potassium and some magnesium. Now look at where Gatorade is. They have become such highly specialized in terms of what they deliver to the athletes. And I strongly believe, proarginine has that use in performance and as a means of performance enhancement, not in terms of taking illicit drugs, but in terms of performance, in terms of how athletes perform, in terms of how I work out, how my exercise capacity improves. I think there is a tremendous utility, because that's science of nitric oxide. I'm not just talking out of my head. That's the science. If I am able to deliver more oxygen to the muscle tissue, and I'm able to get out the lactic acid and the byproduct exercise out more efficiently, then I should be able to exercise more, perform better. And I think there's a means to do that study, to look at how we can enhance performance by using proarginine. And I think that's another area that we're going to look at. And we should look at disease processes themselves in terms of diabetes. Look at it. In the next 30, 40 years, almost 1 out of every 3 Americans is going to become diabetic. Okay? And that is going to cost so much to the healthcare in terms of dialysis, in terms of people losing their eyesight, kidney transplant, peripheral vascular disease, coronary artery disease. Our studies show it reduces cholesterol, it increases good cholesterol, it reduces glucose, but not only that, but it may help deliver the insulin to the target tissue because you're improving microvasculature. So if I can improve better blood flow to the pancreas and to the liver, then maybe the drugs that I use to fight diabetes will also perform a lot better. It is something to look at, something to study. So look at where we are, the potential for it. I am not a market person. I'm not going to talk about promoting proarginine. I'm going to talk about the science. But it is going to impact me in the long run in terms of healthcare costs. Okay, think about what's going to happen. I hope November 2nd changes all that. Because if it doesn't, I'll be looking for a job with Synergy. So 7 out of 10 Americans are going to have directly or indirect benefit from proarginine or from nitric oxide supplement. So we need to look at it, study it, and move forward. And I think that's where we are at. We are in the process of forming a research institute. We're building our own campus in terms of research facility so we can do this kind of research. Our hospital project is going forward, our research project is going forward, and we hope to continue to collaborate with Synergy and companies similar to Synergy in terms of bringing better healthcare products to the market. Thank you very much.